Good morning, everyone. Welcome to the 2020 Strengthening Colorado Families and Communities Conference. We have a bunch of people still logging on, so I'm going to wait just a second to see if we can get the bulk of us here before we get going. I'm getting lots of questions in the chat around, are you muted? Yes, I believe you are all muted. We are expecting 1,000 people this morning, so I do believe that is the default setting. Good morning, everyone. We are just waiting. There's a lot of people signing in, so we're just going to wait a couple seconds for everyone to get in before we get started. So hopefully you can use this time to get settled and finish drinking your coffee. We are in webinar mode, so right now you should only see one speaker, myself, and you will be muted. So just if that's what you see, that's what you're supposed to see. We're getting lots of questions about that. Good morning, everybody. Welcome to the 2020 Strengthening Colorado Families and Communities Conference. My name is Kendra Dunn. I'm the Family Strengthening Director at the Office of Early Childhood in the Colorado Department of Human Services, and I'm going to be your virtual MC this morning. So welcome. We're so happy to have you here. CDHS began holding this conference in 2014, so this is our fourth conference. We convene every 2 years to bring together professionals across the family support spectrum. So basically, anyone working with children and families in Colorado is welcome. We encourage participation from prevention, public health, child welfare, community-based agencies, etc. The real goal of the conference has always been to network across those fields and regions and roles to really help us share what we know about what families need in our state and to share best practices about what's working as we try to serve them. This year, things look a bit different. We are still finding ways to strengthen families and communities. That is a top priority in these times. And just like you, we are going virtual and trying to be creative and innovative in all that we do. So before we go any further, I want to take a few minutes to talk about technology and how to use it to communicate with the presenters. Due to the overwhelming response to the conference, there are more than 1,000 of you that have registered. We will be using Zoom webinar during our keynote presentations, the first of which is going to start shortly. There are two ways to communicate in Zoom webinar. The first one is the chat box, and the second one is the question and answer function. So today we are going to use the chat box to share any website, technology issues, or logistical questions. So we've been getting questions about should I be muted and such things like that. We're going to do our best to answer all of those questions in the chat as they come in. The question and answer function, or the Q&A function, should be used for all questions for the presenter. So because of a large number of attendees, we won't be able to answer all questions. We have monitors that will be looking for themes throughout those questions and asking the presenter during the question and answer session at the end of their talk. All materials, slides, resources referenced during the presentation are linked on the portal in the session zone. We will also put links to the recorded sessions there, and those will stay available on the portal to registered participants only, but only sessions where permission was given by the presenter. So if the presenter did not agree to share the recording, it won't show up. I'm sure all of you know what I'm talking about when I say the portal, or you wouldn't have found your way here right now, because obviously your link to this session was in the portal. It will be open the entire conference. Zoom links will be available for every breakout session. Simply pick whatever interests you. So there was no need to register for individual sessions. We certainly hope you'll join us for the entire conference and all three of our keynotes. We know that it's challenging during the virtual world to really save this time for learning and networking, but we'd like to encourage you to do so as if you were with us in person. You'll get the most out of the conference that way. Tomorrow, Corey Best will join us to talk about building an anti-racist approach to authentic partnership with parents and community. And our last day, Jerry Milner and David Kelly with the Children's Bureau, as well as Michelle Barnes from CDHS, will join us to talk about strengthening families, utilizing a public health approach, and we'll be highlighting the Colorado Partnership for Thriving Families. So many of you are already part of that partnership. We'd love to see the rest of you join us. If you haven't heard yet, Colorado is one of 4 states that was selected by the U.S. Children's Bureau, Casey Family Programs, the Annie Casey Foundation, and Prevent Child Abuse America to participate in a new national effort they're calling Thriving Families, Safer Children. The goal is to really rethink rethink how we serve families and work to build a family well-being system that really focuses from the start on how to create the conditions where all families can thrive. So we will be using that national project as a way to start to look at that in Colorado. It's very exciting work, and this conference will help us carry momentum into that transformative change in Colorado. So we'll be spending Wednesday morning together working on that, and we're very excited about that. One of the best parts of this conference has always been the networking with each other and with partners from across the state in different roles, in different fields. And so we want to make sure that there's still a way to do that in the virtual conference. So we've created several ways specifically for you to be able to meet new friends. On the portal, you will find something called the social zone, and the link will be in the chat. And there's opportunities to do speed networking where you literally can, take a minute or two, meet a person, have a quick conversation about what you're thinking or seeing in the conference. There'll be 2 rounds. Round 1 will be at 1 p.m. and round 2 will be at 1:30 p.m. So we encourage you to take just a short amount of time and come join and meet a couple of new people that you hadn't been connected with prior. There will also be regional fireside chats, virtual gatherings to check in and catch up with one another. Today, the fireside chat will be from 3 to 4 p.m. And again, that will specifically be an opportunity for you to find people near you in the state who are serving children and families. There are a few activities in the social zone that are for your self-care and well-being, because we know that starts with our workforce. So there's yoga in the mornings being offered, and there is also trivia tomorrow for those of you who are good at that. And then we'll be doing a photo scavenger hunt throughout the conference. All of those things can be found in that social zone. If you're a social media user, you can also follow and connect with other attendees and presenters using our hashtag, which is hashtag SCFC 2020. So it stands for Strengthening Colorado Families and Communities 2020, SCFC 2020. So let's see here. What else do you need to know? We're also aware that many of you have coworkers sharing your space, and they may need a few meaningful distractions in order for you to enjoy the conference and absorb new information. So from story time and drawing to playing domats and virtual Lego challenges, laundry art and STEM challenges, the activities found in the Kids Zone were selected to bring the protective factors to life for your children and to help them be able to participate in the conference as well. And to be clear, I am talking child coworkers. I don't think there are resources in there for your pet coworkers, but hopefully they will be joining us as well. Lastly, we have a resources zone, which highlights some great resources that could be useful to you in your work. We want you to check that out for sure. Everything is linked in there. If you are looking for something during the conference and can't find it, simply use the contact form at the bottom of the conference website to contact us. That will be being monitored periodically, and you will get a response. Lastly, I have some thank yous. These events don't happen by themselves. We have a fabulous conference planning committee that has been meeting for almost a year to plan this, and honestly ended up having to plan 2 conferences, the one that was going to be in person, and then the new one that happened virtually. So first and most importantly, want to thank our partners Illuminate Colorado, who co-host the conference with CDHS. I also want to thank like I said, everyone who was on that planning committee, and for your dedication and thoughtfulness, and honestly creativity as we try to figure out new ways to make this meaningful to everyone. I want to thank our presenters who've really put some thoughtful breakout sessions together on new topics that are really relevant to the times we're living in right now. And so we are just so thankful that they kind of dug in and customized presentations to really be meaningful for you guys this week. Thank you guys for your hard work. Thank you for showing up. Honestly, when we sent out the registration, I wasn't sure if we would get the response that we have come to expect over the past years. And you guys blew us away. So we are so grateful that you are here and are excited to learn together with you. CDHS is proud to make this opportunity available to everyone in Colorado interested in strengthening families and communities. And we are very excited we were able to do that this year at no cost. Obviously going virtual helped with that a little bit. Now I'd like to turn things over to Mary Alice Cohen. She is the Division Director for the Division of Community and Family Support at the Office of Early Childhood and CDHS. And she is going to tell you a little bit more about the goals of the conference and some of the content areas that we hope to cover. Thank you, and I'm going to turn it over to Mary Alice.
Great, thank you so much, Kendra. And thank you to the more than 1,000 people who registered for this conference. It truly is a testament to Colorado's commitment to children and families. I'm so excited that the Colorado Office of Early Childhood and the Colorado Division of Child Welfare could come together again this year and host this conference. We know that prevention happens in partnership. Our struggles in early childhood or public health, child welfare may be different, but our solutions are the same, and that's strengthening families. Children who are cared for in stable environments with access to health services, nutritious food, safe water, stable housing, and high quality learning environments are better able to develop the skills that they need for success in school and in life. Babies' brains require stable, caring, interactive relationships with adults at home and in childcare and in the community. Creating the community conditions where families can thrive requires collaboration across the family support continuum. We hope to accomplish several goals together through the course of this conference. First, this is our opportunity to create space for connection. Working together maximizes resources. And this is different in that we can't go from one table to the next or join each other for lunch or for breaks or for s'mores afterward. But we're going to try this in a new way, as Kendra just outlined, to really maximize our resources and collaborate in relationships in new ways to help the families and the communities we serve. So we have a block of presentations that will offer examples on how to shift our practice, and we're going to showcase some new collaborations. We'll have presentations on concrete resource sharing and referral practices. Second, we want to facilitate ways for participants to develop and implement anti-racist and anti-discrimination practices so that all of our children reach their full potential. And what we mean by this is that no matter what zip code a child is born in, or what the color of their skin is, or what physical disabilities they may have, that all children develop to their full potential. So we hope you will join us in our commitment to developing and implementing anti-racist and anti-discrimination practices. But how do we actively prioritize anti-racism in our relationships and in our communities and in our workplace and systems? And how do we sustain and institutionalize that change? I know many of us feel like there's such momentum right now. So how do we truly maximize this and make sure that it's sustainable over the long term? What conversations need to happen to recognize the things that make us uncomfortable? And how are we actively seeking change? Presenters will help you answer some of these questions for yourselves as well as your organizations. So third, we need to recognize, reflect, and create a space for self-care. I heard a presenter last week share about 3 pandemics. So we have a pandemic around COVID-19, a pandemic about unveiling racism, and then a pandemic around all the economic pressures that many of us are feeling and our families and our communities are feeling. So more than ever, we really need to hone in on some effective self-care techniques for ourselves, for the families that we serve, for our teams, for our workplaces. So we'll have a number of sessions to help us with this. We'll actually have the opportunity to practice self-care. And then we'll discuss techniques or activities that will help individuals, families, and workplace environments in the area of self-care. And then we'll have some other opportunities that, like what Kendra mentioned about yoga in the morning for taking care of ourselves. So fourth, the conferences are traditionally a time to reinforce best practices and to learn about new content and strategies in our fields. So since the last time we met in 2018, there have been many best practices that have been established in prevention. So this is a great time to learn about how can we strengthen families in our communities, and then how can we promote the protective factors. What new skills can we develop and learn? And then how can we explore new research that needs to be shared? So finally, this conference is a time to showcase innovation. As agencies and organizations have had to shift how they work during this period of COVID, there are a tremendous number of communities and organizations that have collaborated in new ways to meet the needs of families. Several presentations will offer lessons, lessons learned, and innovative solutions to adjust to the world post-COVID. I know I am so proud of everyone in Colorado and how we all have responded to do this pandemic and to do everything we can to really support keeping families strong right now. There are so many examples, but a few that are top of mind are wanted to thank our home visitors and how the Hippie and Parents as Teachers home visitors, right when the pandemic hit, when we all went virtual, how they would drive by their families' homes and drop off supplies and curriculum and then follow up virtually to keep the support that these families needed going and to continue to support children and parents being their best in their parenting roles. And our nurses and nurse family partnership, I recently learned how many of our nurses were pulled into hospitals for the COVID response. But those nurses and nurse family partnership that weren't, they all jumped in and supported those nurses that were pulled away, supported their caseload so that our families wouldn't have that interruption in services. And our early intervention providers and agencies, they just did this incredible, speedy, seamless transition all online to continue to support families with the direct services that they needed for their children during this time. And thanks to the Colorado Partnership for Thriving Families Town Hall, for all of you that participated in those town halls, it was remarkable how in real time we were able to figure out what are the challenges and what are the resources to support those challenges during that time. And one of the things that we learned was that families needed they needed diapers and they needed formula and they needed wipes. And so we worked with our emergency response team to put in a FEMA order. And a few of you could be chuckling right now because I think we all got caught up in this crazy bureaucracy around this. But the family resource centers and the early childhood councils, they all stuck in there and we were able to deliver these needed supplies to families. And I've also wanted to thank the child care providers and the early childhood mental health specialists that have adapted during this time. And we actually were able to utilize CARES funding, the CARES Act funding, to support our early childhood providers during this time and families and children. I know a lot of parents were concerned that during this period of isolation that their children may have regressed in their social emotional skills. And I know our providers were nervous and how they were going to work during this transitions to really do their best to support children and families during this time. So we're excited about the CARES Act funding, and boy, we have so much work to do. And we have a fantastic team that is looking at a range of different training to support families during this time, trauma-informed coaching. So we're really pulling out all the stops to do what we can to support childcare providers during this time. And I know there's so much amazing work that has happened in the area of public health and in the area of child welfare. We're going to learn more about all the innovation that has transpired through the time during this conference. So I could go on and on, but I know we want to get to our first keynote presentation. But I want to thank all of you for all that you have done during this difficult time to support families and communities. So now it is fitting that we begin this conference focusing on the positive with our first keynote presenter, who focuses on benevolent childhood experiences as a counterpoint to adverse childhood experiences in research and practice and policy. Dr. Angela Narayan is an assistant professor in the Clinical Child Psychology doctoral program in the Department of Psychology at the University of Denver. She is also an adjunct assistant professor in the Department of Psychiatry at the University of California, San Francisco. She received her PhD in clinical child psychology from the Institute of Child Development at the University of Minnesota, and completed a pre-doctoral internship and a postdoctoral fellowship in the Department of Psychiatry and Child Trauma Research Program at UCSF. Dr. Narayan's research lab at DU examines the intergenerational transmission of risk and resilience from parents to children, with particular focus on the perinatal period as a window of opportunity to buffer the transmission of trauma and promote resilience in both mothers and fathers and their children. Dr. Narayan is also a licensed clinical psychologist in Colorado and serves as a clinical supervisor and instructor of several core courses in DU's clinical and child psychology doctoral program. Thank you, Dr. Narayan, for helping us to get this conference off to a strong start.
Thank you so much. Let me just grip my slides. All set. All right, I think we are ready. Okay, so thanks for that wonderful introduction. So let me just jump in. I really appreciate the brief overview of the work I do in my lab. So just to re-emphasize, and I'm gonna hit these points in the talk today. So I direct the PROTECT Research Lab at the University of Denver in the Department of Psychology, and PROTECT stands for Promoting Resilience in Offspring and Targeting Early Childhood Trajectories. We focus on the intergenerational transmission of risk and resilience. I'm going to specifically talk more today about why I think the pregnancy period is a really opportune window to help buffer the transmission of trauma in families who are at risk for various types of adversity. The main topic of my talk today is going to be on an efficient yet effective method that I'll introduce you to, that I encourage people to use. It's freely available, and I'll say more about that. And I also want to just, throughout the talk, emphasize how important I think it is to use a trauma-informed, culturally sensitive lens in research and clinical work and practical work. So I'll share some insights from participants at the end of the talk today that hopefully illustrate that even if we're doing research, we can still have a therapeutic effect on participants. I am a researcher primarily, but I am also licensed and I have a clinical psychology background. While I am going to be talking about research for, about half the talk today at the beginning, this is not meant to be technical. I'm hoping that all the research I talk about will be viewed and received as translational, and hopefully as clearly as possible relate to work people are doing in the field, in the community, with families, And I'm going to specifically highlight as we go what I think some really key practical implications are. So I don't want to get in the weeds with research. I want to show you how these findings can really be applied, hopefully to the majority of the audience here. So just to give you an outline of where we're going today, I also should say that you're going to see a lot of photographs of trees and pathways, and I'm hoping the reason why I'm showing those will be clear, and I'll tell you in a second how that links to the theoretical perspective that I use. So first, I'll do a few quick slides just on the theory underlying the work that I do, theory supporting intergenerational pathways of risk and resilience. And I'm going to talk for the majority of the time about the Benevolent Childhood Experiences Scale, which I think is a really effective tool to use with families, either in research or clinical or community work, and really highlight the practical uses. So we're going to talk about community mental health, screening in pediatric and primary care, and also how it could be used in home visiting programs. So and then I definitely left time for questions at the end. So if people have questions, there'll be hopefully ample time. So I'm going to go all the way through the slides and then address questions for the remaining, hopefully about 15 minutes or so. Okay, so in terms of just brief overview of theoretical perspectives, so I want to kind of highlight 3 perspectives that really provide a nice foundation and a strong foundation for my work. So there are several perspectives that explain intergenerational transmission of trauma and resilience. One of the key perspectives that I really adhere to is a developmental psychopathology perspective, which I will describe in a moment. This work also really nicely aligns with cumulative risk and resilience models of, thinking about how can we use the information that we currently have about resources, for example, that adults and parents grew up with. So obviously we can't change the experiences that adults had in their childhoods, but that doesn't mean we can't ask about them, leverage them, bring them to the forefront as much as possible in order to help families in coming generations. And then I'm guessing most of the audience is familiar with toxic stress and ACEs models, which will be very relevant to this talk as well, and as you'll see in a moment. So the developmental psychopathology perspective is really nicely illustrated by the diagram of a tree with branching pathways. So in this perspective, we really view the role of early experiences as being fundamental and foundational to lifespan and intergenerational risk and resilience. So early experiences in this talk, we're going to talk about childhood experiences, mostly of adults. So looking back, what was their childhood like? And parents, what was their childhood like? But these also have major implications, obviously, for the childhood experiences of the current generation of children that we're all working with. And this perspective believes that, positive and negative experiences lay the foundation, but experiences that accumulate along someone's life also continue to be really influential in terms of predicting the pathways that they are on, or the pathways that might deviate and that might show impairment or dysfunction, or that might come back and show resilience. So that's why I really view the symbol of the tree as the hallmark of the work that I do. So the other kind of major body of work that I want to reference are the adverse childhood experience studies, which I will not go into lengthy description because I'm guessing most people are familiar with them. These are large-scale studies of US adults that have documented links between higher levels of childhood adversity that adults report back on and higher rates of current mental health or physical health problems, high-risk behaviors, or aspects associated with premature mortality, like suicide rates or early death due to disease. So this is a well-established body of literature. It's been out in the world for over 2 decades at this point. Just to remind people, these are the 10 experiences that characterize the ACEs index. the traditional one. We're going to reference back to this because I'm going to show you some data on the samples I've collected who report high levels of ACEs, and also show you how we can leverage what I'm going to argue is the other side of the story, the positive childhood experiences in the lives of adults that I believe really can work to counteract the effect of ACEs, but are much less emphasized. So, a big portion of my work is a resilience focus. And ever since I was a graduate student, I did my dissertation on intergenerational ACEs. And I've always felt like we're missing half the story by not also assessing positive childhood experiences. So the main question I want to ask for this talk is, how can we leverage positive early experiences as resources, assets, and strengths that are associated with long-term resilience? So as I'm telling you, I'm going to start talking about some of the instruments and tools, and I really hope that these might be practically useful to you to use in your own work, either in research or in community work or even in policy. So my advisor in graduate school, Ann Maston, is one of the leading researchers in child resilience in the world. And so, I drew on a lot of body of research that had already been out there in terms of the favorable nature of early experiences that are positive that's already been documented in the literature. So this isn't necessarily a new concept, but, resilience researchers have developed lists of things that are known to be helpful to people in disadvantaged environments. And what I really saw as missing was an easy way to assess these in individuals at high need. So again, either in clinical settings or in research settings. So a resilience framework seeks to understand how people have strength and people show positive functioning despite hardship or challenge. So you need the challenge or the hardship piece or the stress in order to then examine resilience. And it's really important to understand how something is working, I believe, so the process. So we often distinguish also between promotive factors, which are positive things that help most people regardless of the level of risk. So, positive parenting helps most children, and higher levels of cognitive functioning and talent all are beneficial assets that, regardless of risk being high or low, those things are going to promote better functioning in most people. And then we also talk about protective factors, which particularly help as the level of risk rises. So an example of a protective factor that would only be a protective factor and not a promotive factor is something like a seatbelt, where it doesn't really do much when the level of risk is low, when you're just driving along and there's no sort of hazard. But when there's a collision, the risk goes up, the seatbelt is critical. The same is true for emergency services, right? So you don't need them to help you function in everyday life, but when there's some sort of dangerous situation or threat, that's when they really kick in. There are other factors that are really helpful as either promotive or protective factors. And the scale that I'm going to tell you about, the BCEs scale, I believe can serve both functions. So an example of something that operates in both ways is positive parenting, where it's helpful for most kids, but particularly when there's stress, when there's poverty, when there's violence, higher levels of positive parenting can really function to buffer children from the negative effects of the environment or an exposure or a series of chronic traumas. Okay, so the scale that I'm going to tell you about next, I believe, can function across both of these areas. And that's one of its assets, is that it's really flexible, but yet we're finding that it's working as a resilience promoting process. So in the resilience literature, I saw a gap in efficient yet effective instruments to assess these processes in ways that can be brief and also culturally sensitive. So I want to introduce you to the Benevolent Childhood Experiences Scale, which is a scale that I developed during my postdoc with my advisor, Alicia Lieberman in San Francisco, and I'm going to tell you about some data that we have on the early efficacy of the BCEs scale. So This was meant to be a parallel to the ACEs questionnaire, and then it's brief. It has 10 items assessing positive childhood experiences, and I will show you the exact items in a second. It was modeled after existing instruments already in the literature, but it was specifically targeting gaps that we believed needed to address higher levels of cultural sensitivity. So, and also gaps needing something that was brief, right? So I'm a researcher. I work typically with families who are experiencing high poverty. They don't have a lot of time to devote to research. We want to make sure every minute of their time counts and is valuable. We're not looking to sit down and talk to them for 2 hours about protective factors. We want something that's brief, but also is powerful and can work well. So the Child, Youth, and Resilience measure is probably the most famous measure currently assessing resilience. It does have shorter forms, but it's lengthy and it's an interview. And so, you know, this adds, if you have the time to use that, that's great. But this scale adds in that it takes, as I'll show you, under 5 minutes to administer. When we were making this scale, we also really wanted it to be useful for individuals who spoke different languages. So when we developed it in San Francisco, there's a high level of Spanish-speaking individuals, including monolingual Spanish, not US born individuals. So individuals from Latin America, from Mexico. A lot of families grew up in rural, underdeveloped regions. We didn't necessarily want the items or the questions we're asking them about to be dependent on socioeconomic status or the infrastructure in place in, for example, urban developed areas. So a lot of existing instruments ask about, were you involved in youth hobbies or extracurricular activities or sports teams, which are great things to ask if you were involved in as a child, but not super relevant to children who grew up in rural areas of the world who, you know, helped with the family's farm and were involved in the agricultural industry and didn't have access to organized civic activities. Okay, so here are the items. I will just pause and let this screen stay for a second. And I'm also going to say this is a freely available instrument. I will share my email at the end of this talk if people are interested in having a copy of this. Again, freely available to use, so you can go ahead and email me. So this list of items is not meant to be exhaustive. Just like the ACEs scale, not meant to be an exhaustive list of every possible traumatic event you could experience as a child. This is not meant to be exhaustive of every positive experience or resource you could have. But these are 10 things that we started with in the pilot study that we felt like these are hopefully particularly meaningful to most people, no matter where you grew up in the world, no matter what language you speak, no matter if you're from a rural or underdeveloped region or not. And we are working on additional items as well. So what we did for this first study to see, okay, so we have these 10 items that we developed with different individuals who had extensive background in research and clinical work with multicultural individuals. Will this operate in predicting more positive long-term outcomes, specifically after accounting for ACEs? So that's what we would hope. So in the first study, we examined whether higher levels of BCEs, so that's a total score out of 10, so you literally just count up the number of yeses on the scale, would predict lower levels of psychopathology and stress in adult pregnant women. And I'll tell you why pregnancy in a second. So we started with mental health because during pregnancy, we know that there's a lot of literature suggesting if mothers have mental health problems and are under a lot of stress, that can affect fetal programming of cognition, temperament, biology, and psychopathology in children. So psychopathology and stress were two key outcomes we wanted to look at in mothers during pregnancy. And we also tested whether, after accounting for the women's ACEs, do we see that BCEs over and above ACEs work to lower psychopathology and stress during pregnancy. So why pregnancy? I view pregnancy as a foundational period for development, both moving forward and looking back. So it's a key period when adults are looking towards the future and thinking about, how do I want to lay positive roots for my new baby's development, whether it's the first baby or it's another child in the family. But it's also a time when adults are looking back on their childhood roots and thinking, how do I want to do things similarly or differently than what I experienced? So I view pregnancy as a period of hope and anticipation to really leverage optimism and strength, and also a period when individuals with trauma histories, so that's including pregnant women as well as fathers expecting a baby, may be particularly haunted by their pasts. So for these two reasons, it's a great time to intervene if necessary. So for this particular pilot study, we had 101 pregnant women participating in San Francisco. So first I'm going to tell you about some data collected from San Francisco. Then I'm going to pivot and talk about data collected here in Denver. We recruited families from the Zuckerberg San Francisco General Hospital, which is the public hospital equivalent to Denver Health and Hospital Authority here, that serves the most low-income families. We do see a wide range of socioeconomic diversity there, but it specifically serves families who are undocumented or medically uninsured. And so we had mothers come in and participate in study visits where they completed instruments on mental health and stress exposure during pregnancy, as well as ACEs, and I'm going to call the variable BCEs. So that's benevolent childhood experiences. So we have ACEs and we have BCEs, and we kind of picked those, we picked the BCEs to kind of be, the A and the B, so the two components. So this sample was pretty at risk in terms of not necessarily being that young. We did have some individuals participating who were still in the teenage age range, but everyone was at least 18 or older, so they were all adults. We had a very ethnically diverse sample where the largest subgroup reported identifying as Latina, followed by African American and white, and then a high proportion of individuals who identified as biracial, multiracial. 25% of the sample was monolingual Spanish speaking. So we had the BCEs administered in Spanish by interviewers who were bilingual. And we see, a lot of women, it was not their first pregnancy, but they were experiencing a lot of poverty. So a little over 2/3 of the sample reported living below the poverty line in San Francisco. And I'll tell you a little bit more about the stress and the risk exposure during pregnancy in this sample. First, I just want to show the rates of ACEs reported in these 101 pregnant women. So these are the same items I just showed that characterize the traditional ACEs scale. And unsurprisingly, we had pretty high rates of all the different types of ACEs across the entire sample. And I will just pause for a second. So I'm going to show these numbers again in the next slide. So on the left, you'll see the ACEs that I just showed you. And then the counterpart, now we see the rates of BCEs reported in this sample. And again, item by item. So the good news is, even though there were high rates of ACEs, there were high rates of BCEs, with the mean across the sample of low-income women being almost 8 BCEs. So the mean was 7.84. So this is showing that even though the sample was reporting a mean of slightly over 4 ACEs, which is a threshold documented in the literature that I'm guessing a lot of people are aware of, 4 or more is associated with multiplicative exponential levels of risk if you experienced 4 or more ACEs as a child. So we're seeing the sample does have that exponential risk, but they also have high levels of BCEs. The case I'm going to continue to make in this presentation is that you can have both. You can have high ACEs and you can have high BCEs. So one does not preclude the other, which is why it's so important to assess both. We found that 28% of the sample, 28 out of 101, had all 10 BCEs. So again, a really high potential for resilience from the childhoods of these women in this sample. Okay, in terms of just the mental health symptoms that we discussed, we assessed depression symptoms and PTSD symptoms as kind of two of the most, in my opinion, two of the most important mental health problems a woman could experience during pregnancy. So obviously there's a lot of universal screening efforts for depression during pregnancy. We found that 46% of the sample reported being above the clinical cutoff for depression during pregnancy. Although we didn't in this study specifically focus on postpartum depression in this BCEs pilot study, 30% of the sample continued to have depression at the postnatal period. So just showing you this is a sample that has high levels of mental health issues. I also believe it's really important to assess PTSD symptoms in pregnancy, especially if we're looking at trauma history in women, because oftentimes there are differential effects of trauma history on mental health problems, and we see PTSD as being one of the most salient mental health outcomes that often is unaddressed in prenatal screening, that I think is really critical to address, that I believe should be implemented in policies for prenatal care. And we had almost a third of the sample at the clinical cutoff for PTSD, according to the PCL-5 scale put forth by the National Center for PTSD. And then the other outcome we assessed was stressful life events. So this is using a cumulative risk model where we asked women during the study visit about a variety of different stressors that they may have experienced during this specific pregnancy. And we took these 10 potential stressful life events and summed them to form a cumulative risk score during pregnancy. And you'll see a lot of women reported high rates of different types of stressful events. So just to draw your attention to a few, 62% reported the current pregnancy was unplanned. Almost 30% had been exposed to community violence during this pregnancy. Almost 20% had been homeless at some time during this pregnancy. So we had a fairly high rate of homelessness. If people are familiar with the Mission area of San Francisco, where the San Francisco General Hospital is located, it's a very vibrant community, but there's also a lot of poverty immediately around the hospital. And we found that some women reported they were actually living in tents, homeless during the pregnancy. So again, a very high level of risk. Okay, so just in terms of simple analyses showing the preliminary efficacy of the BCEs scale. So we find that higher levels of BCEs, so higher levels of that total score reported by women, were significantly associated with, lower levels of each type of psychopathology during pregnancy. So that's a typo that should say higher levels of BCEs significantly associated with lower levels of each type. So lower levels of depression, PTSD, perceived stress, and number of stressful life events. We also find that BCEs and ACEs are only modestly associated with each other. So they're only correlated at about negative 0.36, where higher levels of one is only modestly associated with lower levels of the other, suggesting again that these are relatively independent experiences. And in this sample, mean levels of BCEs did not differ across women who were English speaking versus monolingual Spanish speaking, women who identified as Latina versus African American versus white, or women who reported being born in the US versus foreign born. So this is really nice tentative evidence that different cultures don't systematically report different levels of BCEs. This scale is operating in a similar way across cultures. The items that we picked aren't biased towards one particular racial or ethnic group or one particular group of people being born specifically in the US. Okay, so we also find that after counting for covariates and ACEs, higher levels of BCEs continued to significantly predict specifically lower levels of PTSD symptoms and lower levels of those pregnancy stressful life events that I showed you, the 10 items that we added together. However, higher levels of BCEs did not significantly predict lower levels of depression or perceived stress scores, which is the perceived stress scale that's commonly used to assess kind of difficulties coping during stressful times. So the point I want to make here is that BCEs may have specific protective effects for certain outcomes, whereas for other outcomes like depression and perceived stress, ACEs may continue to be even more powerful. Okay, so to sum that up briefly, higher levels of BCEs directly predicted lower levels of PTSD symptoms and fewer traumatic or stressful life events during pregnancy above and beyond the effects of ACEs. Okay, but then one of the most important questions that we set out to address that we hadn't answered yet is, what about women who have high levels of BCEs and high levels of ACEs? So how might these positive early experiences counteract or coexist or outweigh the long-term effects of ACEs? Okay, so that's the second critical question we want to ask for the very first time. So what we did is we examined how these 101 women fell into different groups based on their ACEs and their BCEs scores. And what we found was what I thought was fascinating. So we had one group that was 38 women that we called them the high BCEs, low ACEs group, because as a group, this subset of women reported approximately 9 BCEs, but only 1 ACE. Okay, so despite this being a poverty sample, we have a group of over a third of the sample saying I had a lot of BCEs and my level of ACEs were actually fairly low. We had another group that was 34 women, so about a third of the sample, that had high on both. So they had 9 BCEs, but they also reported 5 ACEs, which is above that 4 or more threshold. So we consider this to be a high ACEs group. And then we had a third group that was slightly over 25% of the sample, where we call them high ACEs and low BCEs. So they had 6 ACEs and they only had 5 BCEs. So I want to argue in a second why we think this might be a good threshold for low BCEs. Okay, but first, what we did is we examined the mean levels of the mental health problems and the stressful life events in these 3 groups in the pie chart. And what we found is that women who had high on both, so high levels of ACEs, but also high levels of BCEs, had significantly fewer PTSD symptoms and stressors than women who had the high ACEs, but the lower BCEs. So women who had high on both, pretty high ACEs, but also high BCEs, actually looked more similar to the group of women who had the high BCEs without ACEs. So what this is telling us is that even if you have high ACEs, your high levels of BCEs might protect you. So you're not doomed by any means if you have high ACEs. We just need to assess and we need to recognize and we need to leverage those high BCEs as well. Okay, so here is the first point I want to make in terms of practical implications. So even if you have that very high threshold of ACEs, you may show more resilient long-term functioning, even if you have BCEs. So we need to assess both. And the BCEs scale may be particularly helpful to identify individuals who are at risk, either in place of the ACEs scale, if you only want to administer one, or in conjunction, if you have time to assess both. So why did we consider individuals with 5 or less BCEs to be in the low group? Because those individuals showed much higher mental health problems. So we also found that their levels of ACEs were higher than their levels of BCEs. So if you think about it like a scale, and we need more research evidence to really replicate this point, but I think of it as like a scale that's tipping. So, you know, the group that had both, their BCEs were still slightly higher than their ACEs, but the group with high ACEs, the scale is now tipping in favor of ACEs. And low BCEs, I mean, a score of only 5 on the scale to me, that signals a fair amount of risk, because that means that an individual is thinking about all 10 of these items, and we're saying, did all of these items happen just at least at some point between 0 to 18? If an individual in a research or clinical setting that you're working with is saying no to half of these items, 5 or less, that means that at no point in their childhood did they have 5 of these items. That to me signals this individual might be in particular need of leveraging the positive things that did happen to them, and then thinking about additional ways to implement supports and resources so that, for example, their children have higher levels of these positive experiences in the next generation. So I'm just going to pause for a sec and then transition to providing you a little bit more evidence to, again, support the claims that I'm making, because I acknowledge, obviously, this is only a sample of 101 women. This is a pretty small sample, and it was only one study. So we have found, and these are both papers published by my excellent doctoral student, the first of which is not done in a pregnancy sample. It was a homeless set of homeless families in Minneapolis. She found that higher levels of BCEs predicted homeless mothers lower odds of psychological distress, while higher levels of ACEs predicted higher sociodemographic risk. So things associated with single parenting, lots of kids in the household, not having a partner, etc. So we see differential prediction of ACEs and BCEs, where BCEs predict certain outcomes and ACEs might predict others, depending on the sample. We also found in this same pregnancy sample that higher levels of BCEs not only predicted lower mental health problems that I just told you about, but it also predicted lower levels of women's risky reproductive planning, that should say lower, including teen pregnancy, lower rates of teen pregnancy, lower rates of lifetime unwanted pregnancy, and lower rates of the current pregnancy being unplanned. And this was particularly true for BCEs that began before age 5, but not after age 5. So higher in the BCEs, lower in the risky reproductive planning. Now I want to shift and answer a question that people might be thinking about. What about fathers? So far, all of this research is associated with women, mothers, people expecting a baby who are pregnant females. So we've been collecting a sample in Denver that's meant to be similarly recruited to the sample in San Francisco, but also looks at the men who are expecting a baby, the partners of the pregnancy sample. So we've been in the past couple of years collecting a sample of families expecting a baby and delivering at Denver Health, which is the public general hospital here that I'm sure a lot of the audience is very familiar with. We have 175 pregnant women that we've collected. Again, a highly ethnically diverse sample. The sample here in Denver, the largest subgroup is identifying as white, but we still see good representation of Latinx and African American. Same for the fathers. We have good representation of 3 racial and ethnic groups. And we again see a high number of ACEs in the sample. The sample is only recruited based on planning to deliver at that hospital and being at least 18 years old. And in this case, in this city, needing to speak English well enough to participate in the interview. Unfortunately, here in Denver, I don't have the research personnel behind me that speak fluent Spanish as much as we did in San Francisco. So the sample is slightly different, but it's a poverty sample again, high numbers of ACEs, but also very high levels of BCEs, which is again what we want to see. We want to see that high potential for resilience. Again, we see with this larger sample that also includes men, there are no significant differences on mean levels of BCEs between groups identifying as a different racial and ethnic identities. This is true for men and for women. So it's again suggesting BCEs might be present at comparable levels across racial and ethnic groups, and good evidence that this tool may be culturally generalizable, at least across these 3 groups. And we have colleagues doing pilot work with other families who identify as other racial and ethnic groups, like Native American and Asian. We also saw no significant mean differences in the number of ACEs across these 3 racial and ethnic groups, indicating that certain racial and ethnic groups are not more likely or less likely to report higher or lower levels of ACEs. However, one thing we did see that was interesting between women and men that I think is practically useful is that here are the rates of BCEs reported in 175 pregnant women in purple and 121 fathers to be in green. And I want to draw your attention to 3 items that emerged as showing the largest differences in rates between men and women. So for example, 93% of the sample of mothers reported having at least one good friend during childhood, but only 84% of fathers. So again, these are both high percentages, but we're seeing a little bit of difference between men and women. We see a similar difference in enjoyment in school, with mothers reporting this positive childhood experience at over 10% higher rate than men. And then for BCEs number 9, we see a shift and a reverse, where we see women reporting lower rates of liking themselves or feeling comfortable with themselves growing up, and this being more true of men. So again, just to hopefully convince you of the utility of this scale, we see that ACEs and BCEs are often independent, separate sets of experiences. So now at this point, we have data in 5 different samples. So we have the San Francisco low-income pregnant women. We have the 2 Denver groups of men and women that I just told you about. We have the Minneapolis homeless mothers, and we have a large longitudinal survey sample that I'll tell you more about in a second. In each of these samples, we see very modest correlations between ACEs and BCEs. So just because you had one, that doesn't mean you don't have the other. In this large community sample, this is the first time I've looked at rates of ACEs and BCEs and their associations in a community sample that does not identify as having a lot of ongoing risk factors like poverty or trauma. So we did a survey sample with 550 US adults that were represented from 47 of the states. We asked them about their ACEs and their BCEs and their mental health. We found that after accounting for demographics and ACEs, higher levels of BCEs significantly predicted lower levels of depression symptoms, anxiety symptoms, and PTSD symptoms in young adults. These people were between 19 and 35 when they completed the study. We found that ACEs, but not BCEs, predicted higher levels of aggressive behavior, alcohol abuse, and substance abuse. So here we see kind of similar patterns as that first pregnancy sample, where BCEs do counteract ACEs for some things. In this case, the mental health, trauma, internalizing symptoms, but not necessarily for the more externalizing or substance use outcomes. So when you're thinking about using the ACEs or the BCEs scales across different samples or populations that you work with, you may see that BCEs specifically helps to, reduce the effects of certain outcomes. So I don't want to make the claim that BCEs have universal positive effects across every type of outcome. I really think it depends on the type of sample. But these are interesting findings, and I think that they're showing the utility of, for specific things, BCEs are really, really powerful. But ACEs are also really powerful forms of childhood adversity and may continue to be predictive of certain negative outcomes. The other thing I want to highlight that I hope is practically useful is that across these 5 samples, so pregnancy samples in 2 different cities, one of which include men, the homeless sample from Minneapolis that was not pregnant, and then this larger community sample that was US young adults. Across all 5 samples, 4 of the BCEs were reported at greater than 80% in everyone. So more than 80% of the entire sample in each of the 5 samples reported having at least one safe caregiver, at least one best friend, at least one caring teacher, and opportunities to have a good time growing up. So what does this mean? This tells me that these items are present for most people. So A, asking about them, you're probably going to get people saying yes. This is going to be experience that'll hopefully elicit positive memories and pre-existing strengths to potentially then have conversations about with your clients or your patients about how to leverage this and have this be present also in the next generation for children. So very few people are probably going to say no to these. If they do, however, that could also be an indicator of risk. So needing to go in and do some resilience promoting intervention for families that don't have these things. On the flip side, we also found that there were specific BCEs systematically across these high risk versus lower risk samples that were less likely to be endorsed as positive. So these 6 BCEs were reported across 4 out of 5 samples at a rate lower than 80%. So less than 80% in 4 out of 5 of these samples reported they did not have beliefs that gave them comfort growing up. They did not have enjoyment of school. They did not have good neighbors. They did not have another supportive adult who was not a caregiver, but someone that could provide love and support. They did not like themselves or feel comfortable with themselves. And they did not have a predictable home routine. So while, a large group of people typically did say yes to these items were systematically reported at lower rates across all samples, regardless of risk. So adults or parents who report lacking these specific items or resources, again, it may be a flag for you as a practitioner or a community health worker or a home visitor or a researcher that these things are less common. We need to figure out, but we do believe they're important because higher levels of total BCEs are showing these predictive long-term effects. We do believe they're important. How can we specifically target implementing these in this family so that their children have them? Okay, so continuing this thread of practical implications, I really believe that the BCEs scale, and I'm hoping I'm starting to convince you, could be a useful tool in community health and child welfare services, particularly to give to adults who are seeking services or parents who might be CPS referred, to start a conversation about the positive childhood experiences that these adults had in their early lives, that they can draw on, that they can specifically plan to concretely implement in the lives of their children. This tool could be used to inform case planning, reunification, how to leverage the strengths of parents in need. I also want to make another point that I think the BCEs scale could be particularly useful in more universal screening efforts. So child healthcare policy is starting to recommend universal screening of ACEs in pediatric settings. This is a practice that's been recommended in the last 5 years or so. It's not necessarily the case that it's done everywhere, and there are so many barriers with ACEs screening. So obviously, providers don't necessarily have time to screen for ACEs. There's billing issues. A big question is, if a family reports high levels of ACEs, then do you feel compelled to do something? What if you don't have the referrals in place? Is that the role of the primary care provider, the pediatrician, to then provide those referrals? So a few points I want to make here. Parents are typically not regularly screened for ACEs. I believe that they should be if their children are screened for ACEs. So if we're asking a parent to report on their child's ACEs, I believe that we should also be asking a parent to talk about their own ACEs. And I'll make that point again in a second. I also want to say that a high ACEs score in a screening context does not necessarily mean that referrals are needed, because we know that a lot of individuals can have high levels of childhood trauma, but not be experiencing a high level of current impairment. So seeing a high ACEs score doesn't necessarily mean you must intervene. You can ask them, and you should also assess their ongoing mental health and stress. And in that case, that would warrant an intervention. But a major barrier is that, I think there's a misconception that high ACEs must mean you must do something. And I think it's a channel for starting a conversation. What I really recommend should happen is that when parents are asked to complete ACEs screeners on their children, providers should also ask parents about their own histories, not only of childhood adversity or ACEs, but also about parents' histories of positive childhood experiences, which I've hopefully convinced you are equally positive in the other side of the story that's often missing. Because I think not only does that target resilience processes that are previously uncovered, but it also communicates to parents that providers acknowledge and value the parents' legacy of early experiences that have shaped them as people, in addition to shaping them as caregivers and protectors of children. So a lot of the policy work done with the ACEs scale is recommending screening for ACEs in children and all these interventions at the community level and the institutional level and the primary care level, without, in my opinion, enough attention to, we need to ask parents about their legacy. We need to acknowledge that parents have resources. We need to support parents in things that are going well. We don't necessarily need to start for the first step with all these other interventions that don't acknowledge the parents' legacy of early experiences that might be the most proximal predictors of their mental health and their stress and their capacity to then protect their children from ACEs. And one of the last points I want to make is that while the BCEs scale was developed specifically for adults, similarly to the ACEs scale, where it was developed for adults to think back to their own childhoods and report on what was there, I do believe there are really nice ways that this scale could be used for parents to report on their children's current BCEs. So it would need to be slightly modified. And I do believe that it's difficult to go in and ask a parent which of these positive things is your child experiencing, because parents want to believe, obviously and understandably, that their children are experiencing a lot of positive things. But one strategy to do this could be show them the whole list of 10 items and say, which of these are you more confident in that the child has? Which of these are you less confident in? Or which of these are areas of weakness for your family or for your child that we can really have a conversation about targeted interventions or supports or resources that you need. The other thing that I think would be great, and there has not been research done on this yet, but I think there should be research and clinical work done, is to see if there are outside people who know the family really well, who could complete the BCEs scale about the current level of positive child experiences in children in the family. So home visitors who know the families really well are excellent sources of observation and identifying which BCEs are really effective and strong in this family, and which BCEs might this family benefit from increasing. So in terms of putting it all together, I've hopefully convinced you that this could be a practical counterpart to the ACEs scale in diverse families and settings. I also want to make the point that in the original ACEs studies, the majority of adults did not display poor health or functioning, but very little research has focused on this flip side. So, we see and we hear so much messaging about the ACEs index or your ACEs score being really problematic, but the majority of individuals didn't go on to have these negative health outcomes. It was only about a third of the sample in the original studies, high ACEs to bad health or poor well-being. So what is accounting for the fact that a lot of people have higher ACE scores but don't go on to show poorer health or higher rates of disease or higher rates of morbidity or mortality? We need to actually also get in there and ask about positive child experiences. Hopefully I've convinced you that the BCEs can be an effective tool. The last point I want to make is that one of the most practical implications is that this elicits a lot of positive feelings in participants or patients or clients when you're administering it. So we ask participants in our studies, what was the experience like for you to do this? We're not specifically pulling for anything that they would say in particular, but kind of just asking that open-ended question, trying not to be leading in any way. We have a lot of individuals say this was really, really helpful. So I wanted to just highlight a few reflections from participants, both mothers and fathers. So for example, the first was a pregnant woman saying, this was very self-reflective. I got a chance to look at myself and pull out emotions to better my family. A father said it helped me pay more close attention to the things I didn't think were important about raising my kids. It also helped me reflect back on my family relationship and past experiences. And then another mother said, I was able to remember really good parts of my childhood and about my family. I also got to think about what I would like for my daughter. So again, we can't necessarily change the level of positive experiences or resources that a parent had as a child, but we can change the way they think about them, the way they remember them, and the way they use them and implement them in the next generation. So I think the BCEs is the first step in starting that conversation. All right, so the last thing I just wanted to say is here's the scale again. We have a lot of colleagues around the world working hard to translate this. So it is currently now available in several other languages. It's free and available to use in clinical worker research. So if you're interested in having a copy, which is just a one-page PDF, feel free to email me. So this is my email at DU, and I'd be happy to send you a PDF that you can then use in your work. So that's all I have. I want to just acknowledge the funding sources that made this work possible. My mentors, specifically my postdoc mentor, Alicia Lieberman, who was one of the key co-developers of the scale. My amazing lab, including my 4 excellent current PhD students who are so productive, and all the participating families, both in San Francisco and here in Denver, who share their stories with us. So I will stop for questions.
Great, thank you, Angela. We do have 10 questions, so we may not get to all of them, but let's go ahead and see how far we can get. BCEs questions are all leading questions. What do you do if a respondent answers maybe or I'm not sure? And then also, do you intend to collect more information from questions besides yes or no questions?
That's a yes. So we tried to not make them leading. We do believe that saying yes or no is fairly easy to these questions. Obviously, for people who have lower levels of BCEs, this might be a slightly less positive experience because they're starting to think like, wow, no, I actually didn't have this. So I don't proclaim to say that giving the BCEs scale is going to be positive for everyone. I think it's positive for a lot of people. But we do have, we have a high rate of people saying no to these items, as I showed you in those percentages. So, I think the issue of it being leading would be more the case if you're asking a parent currently about their own child. I think a lot of parents might have hesitancies to say, no, my child doesn't have opportunities to have a good time. That might be a little bit of a biased question, which is why a home visitor, someone who knows the family well, might be more suited to objectively complete the BCEs scale about the family than going directly in to ask the parent. But when we're asking parents about their own childhoods, we don't have reason to suspect that people are not being truthful. We also do a lot of work in the clinical research interviews, the study visits with parents, to make them feel really comfortable before we go in and ask these questions. So we typically don't start asking the ACEs or the BCEs. We ask them a lot of other background information.
Great, thank you. The next one is, these BCEs seem really, to me, to correlate to the 40 developmental assets. Do you have any thoughts on that?
Yeah, so we drew on the literature, the resilience literature that I definitely don't proclaim to have, I didn't do a lot of that founding work. And so we were hoping that these echo a lot of the previous work out there. To address the other part of the question before, we are working on piloting an expanded BCEs scale with about 12 more items. So hopefully there'll be findings to come soon about that.
Great, thank you. The next one, a few of the BCEs relate to community factors, neighbors, school, teachers. Can you offer interventions at the community level that were learned from the previous research?
Yeah, that's a great question. I think that, this could also be a tool that, you could have a teacher who knows a family or a child well, assess BCEs. And, we also, in adding these particular items that aren't just in the family, we recognize that sometimes families can be sources of risk for individuals or children. So if you're finding that, say, for example, a parent is completing the BCEs scale about their own childhood, and they're saying no to a lot of questions in the family, but yes to a lot of questions in the community, or vice versa, that could be a conversation to start with that parent about what was that like for you to not have the resources in the community or the resources in the family. How does that pose any sort of challenge for you now in raising your kid? How can we help you in terms of what your kid might need in terms of friends that are supportive of them or teachers that look out for them. So again, this is a conversation starter in a lot of ways. It doesn't directly point to specific interventions, but hopefully, this is the BCEs scale is not something that a lot of people have been asked before. We have participants saying, like, nobody's ever asked me about positive child experiences in my own life. I've always only been asked about negative things and things that weren't going well. So, and that's a fundamental realization that, like, okay, we need to just ask in the first place. And then the next step is intervention planning, which of course is complicated. And, there's a lot of steps there as well.
Okay. So this next question kind of builds on that. Many factors of the BCEs are related to healthy social connection and community. Can you talk more about this factor's power to heal and practical social isolation, often seen in tandem with physical and mental illnesses? Can you speak to ways we could improve connection and strengthen relationships in the way we support families and how we treat depression, anxiety, PTSD, trauma, etc., in ways that are not happening for the most part today?
I think I missed, there
There's
was
a lot in there.
in the part right after about healthy connections in the family, something about like,
yes, right. So we're kind of talking about BCEs and the positive implications for building social connections in communities, and then the flip side of that being loneliness and social isolation, that's connection to physical and mental illness, and really trying to think about how to use this tool and the research around BCEs to really think about how we more proactively support families with depression, anxiety, PTSD, trauma, etc.
I think that not having supportive family environments and specifically having abusive family experiences is what really predicts trauma. And this, I think, is starting to show in our preliminary work, obviously, that needs to be replicated, that we find typically that ACEs and BCEs really tend to predict trauma, long-term trauma. So higher levels of ACEs, lower levels of BCEs, we see PTSD symptoms as a really powerful outcome. A lot of the work we've done with low-income families is showing that depression is often more affected by current proximal stressors in adults' lives. So issues with the romantic relationship, issues with the co-parenting relationship, mothers feeling like they're isolated, having a lot of ongoing contextual stress. Of course, COVID being a major factor affecting social isolation and hardship currently. I particularly believe that PTSD is what is really affected by these negative early experiences or low levels of positive experiences. We need more work to support this, but this is starting to show this. Higher levels of ACEs and lower levels of BCEs were robust predictors of PTSD symptoms. So I think that specific outcome needs to be addressed. And we know that in the intergenerational transmission of trauma, PTSD symptoms are often responsible for the link between adults' history of childhood adversity and higher levels of trauma in their children's lives. So all of these mental health outcomes obviously are important to address, but I think looking at, is this family experiencing a high level of parental childhood trauma versus current contextual stress? What are the mental health issues that are affecting parents? It might be that depression or PTSD or anxiety are higher or lower for certain people. And using brief scales to assess those, and the scales that I talk about today, the Edinburgh Prenatal Postnatal Depression Scale, specifically depression and pregnancy, but it's free to use. The PTSD scale, which is the PCL5, it's again free to use. It's available on the National Center for PTSD website. So brief free assessments are something that we use as much as possible in research and clinical work because they're accessible and they're short and they get at the questions that we're asking. So I think increasing the repertoire of assessments that are brief provides the breadth and also the comprehensive insight into what a family might need.
Great. I think we're going to ask one or two more. We're getting close to our time here. How would you suggest screening for ACEs and BCEs in early intervention, like IDA Part C specifically?
I'm guessing that's early intervention with current young children.
Yes.
Yeah, so I would recommend trying to use the scales in a way that minimize bias and social desirability in parents who are completing them about their young children. So again, that both of those skills are meant to be for adults thinking about their own childhoods, which have already occurred, which is why we have that 0 to 18 timeframe. For adults, that's already happened. So it's a little bit trickier to do this with young kids currently. But in the research that we do, when an adult says yes or no, we also then ask them, and I didn't present data on this today, but we ask them at what age or age ranges were these ACEs items or BCEs items true. If you're going in an early intervention and you only have a child who's 4, you're only looking at the early childhood period, and you could ask parents, like, which of these items has affected your child? Which are you worried about? Which ones can we help you implement? Again, I would recommend a close observer who knows the family well, like a home visitor, also weighing in so that you can really get a comprehensive picture. That's not to say that parents are not accurate reporters, and I'm a parent myself. I'm not meaning to discount parental reports, but we know things like current stress, current mental health problems, and history of childhood trauma in parents affects how parents think about their children's needs, view their current symptoms, and view the extensiveness of a child's trauma exposure. So obviously parents know their child best, but there are also other factors that might shape how they might think about these things, which is why home visitors or teachers might be additional valuable sources of information.
Great. Okay, so here's the last question. On a programming level, should direct service providers focus on the 6 lower scored factors to increase the incidence of these for young people?
I think that that's one of the most promising directions of this research. I would say administer all 10 items because it's so quick. And if you administer all 10, you're likely to get a handful of them that are positive and present, that people are like, yes, that was true of me. But then know that the other 6 might be slightly less likely. Again, still the majority of people said yes to these. But, when people said no, it tended to be those 6. So really paying attention to those and then starting a conversation, if possible, with intervention about, okay, how can we, ideally we want all 10 in everyone. And we had 28% of our sample of pregnant women say yes to all 10, but that's still, 72% saying no to at least one and not having at least one of those for any time in their childhood. So the flip side of the BCEs, what people say no to, I think can be equally informative and illuminating as the things people are saying yes to.
Great. Thank you so much, Dr. Narayan. This has been a wonderful presentation. As you can see, lots of interest. I'm sure one of the hardest things about being a keynote speaker today is that you don't get to see the ballroom of people with the applause and their reactions to your presentation. But I just want to say thank you. And I know that there's thank yous in the chat as well. For all of you who have been listening, as you know, we're relying on attendee evaluations to let us know how things are going because we also can't see you. So I want to encourage everyone to complete the evaluations each session. They are found in the session zone. The link to that is now in the chat. And we will see you at 10:30 after break for the breakout sessions. Additional information on the upcoming activities and sessions are all in the conference portal with the Zoom links available in each of the session descriptions. And so with that, I will say thank you, good morning, and enjoy your 30-minute break.
Thank you. Thanks. Hopefully that went well.
It was wonderful. It's such interesting work. So thank you.